So there are two components here. One is coverage, and the other is cost and delivery system reform. Let me start on the latter one because that's been more surprising. When the law was passed, everyone said it solves coverage, it does nothing on cost. And I think since then, the evidence has accumulated that there's a lot more happening on the cost side than people had appreciated. If you told me in 2008 or 2009 that Medicare costs in 2014 would be up a whopping 0.3%, $1 billion so far this fiscal year, the first 8 months of this fiscal year. So on a real per beneficiary basis, significantly negative. If you told me that we would expand coverage, I'll come to that in a second, by roughly 7 million people net of the people who were uninsured previously, and healthcare expenditures would decline in the first quarter of 2014, if I went out and said that publicly, I would have been dismissed as a quack.
Yeah.
And yet that's exactly what's happened. This is a massive, massive thing. If the Medicare trend continues, and we have to talk about what would be involved in it continuing, but if it were to continue, everything you think you know about the long-term fiscal gap facing the country would be wrong. If Medicare cost per beneficiary grow over the next 7 decades at the same rate that they have on average over the past 5 years, the entire long-term increase in Medicare as a share of GDP disappears. And that in turn means that almost the entire long-term fiscal gap facing the entire nation disappears. So this is a big deal. Now, just briefly on those GDP numbers, why was I so excited? Because there were all these press stories based on the initial estimates that are in the GDP that showed a very large increase, a very significant percentage increase, 9.9% in the advance estimate and the 9% when it was revised for the first quarter of 2014. There were all these stories in the New York Times and the Wall Street Journal, blah, 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 that the slow growth that we've been experiencing over the past several years is over, okay? What people didn't point out is that the first two estimates of the GDP numbers are based disproportionately on what the government agency calls judgmental trend, which is otherwise known as making it up, without any real data whatsoever. And yet, if you looked around at the different components, it seemed kind of odd, because if you looked at publicly traded hospital companies, HCA, LifePoint, and what have you, their same-store admission rates were flat to down. If you looked in various other outpatient settings, not a lot of growth. If you looked at employment, it was growing very slowly. If you looked at Medicare, it was not growing rapidly. So where was this magical growth? And we now know that number went from a plus 9% that was made up, and that was the basis for all those New York Times and Wall Street Journal stories, to this morning minus 1.4% in inflation-adjusted terms. In other words, healthcare spending declined, and by the way, it declined even in nominal terms in the first quarter. This is massive. Before I turn to coverage, what are the consequences if it continues?
Yes.
Equally massive. The Congressional Budget Office has, which I used to run the Congressional Budget Office. I can assure you it's not a dynamic agency that likes to incorporate new information in a really rapid fashion. Instead, it likes to move slowly and cautiously. It has marked down our 10-year deficit number. Almost no one knows this. It has marked down our 10-year deficit number by, depending on how you do the calculation, $900 billion to $1.2 trillion because of the ongoing deceleration in healthcare costs. Far larger than any of the policy interventions that people were debating. If that were to continue, it will help raise workers' take-home pay. It will help face our long-term fiscal gap at the federal level, and ultimately will make us better off as a country. I'll turn to coverage just really briefly. I know I'm going on too long.
Okay.
8 million people covered under the exchange.
Yeah.
8 million people covered under the exchange. 6 million new people who have obtained coverage through Medicaid and CHIP. Disproportionately in the states that expanded Medicaid, who have seen a coverage expansion of about 15%. But even in the states that did not expand coverage under Medicaid, there's been a roughly 3% increase in coverage because of the Woodward effect. Somehow people come out of the woodward, they hear that there's Medicaid expansion, they say, maybe I'm eligible for it, and even though the state didn't expand eligibility, there's been an increase in Medicaid even there. The best estimates, and this is rough guesswork, suggest that about half of those people were previously uninsured. So the total is about 14 million, half of that 7 million people. There's 7 million people more today with health insurance in the United States than in the absence of this law. That strikes me as, maybe it's not an A+, but at least an A- grade 6 months in.
Cost and coverage, you're saying. It makes me tired. I'm tired.
Yeah. Tom, is it working?
Would I give it an A+? I wouldn't give it an A+. I would give it, it's working about as I expected, if you'd ask me. I mean, the rollout was a disaster optically. I mean,
Yes.
I think that's unfortunate. The current administrator of CMS is a good friend of mine, so I was not, I feel badly having been through a couple of political disasters in healthcare. But, the problem is, you can debate the numbers about, there's a lot of moving pieces here. Medicare Advantage is shrinking, probably rationally. So Medicare Advantage, which is 31% of the program, actually had real cuts. So when you look at whether it's +8 or -1.4, the real issue here is there are a lot of things I like structurally about the ACA. The major thing that's good about the ACA is, and it's not just the ACA, it's a trend the last 10 years. 10 years ago, you had 12% of people in state Medicaid programs and managed care. Now it's 75%. 10 years ago, you had 2.5%, almost 2.7% of people in private Medicare plans. Now it's 31%. The exchanges are all private plans. The reason this is changing is you're getting away from single payer, price fixed, Medicare and Medicaid, which I never liked. I think that's the problem. Government fixing prices is the problem, to capitation. I think most people, we discussed this morning, when I sat in a plane next to Howard Dean about a month ago, one of the nicest guys you'll meet, and when Howard Dean says to me, you know what, price fixing doesn't work, we got to move to capitation, I'm like, wow. So structurally, the move that's helping here is, and I agree, there's some good things about the ACA, is the move to capitation private plans, because the government setting, I was involved in creating RBRBS in 1989 when I was in the White House working for Bush 1. It just didn't work. You get volume explosion. So getting back to the problems of the ACA, the problem with the ACA is the rollout has worked about as I expected. The problem with the ACA is it's a massive, gigantic, gargantuan, overdone entitlement expansion. And the two things that I have a problem with it, which have nothing related to the rollout, are that one, you've got 20 million people that are going to be added to the Medicaid rolls over the next decade. Some number now. I happen to think those are the people that should be covered. We should cover poor people first. It's the right thing to do. The problem is Medicaid is a $600 billion program that's a fiscal disgrace. There are no rules. Every state cheats. All of you know there's provider taxes, disproportionate share payments. If you can find me one state medical director who can tell you what his match rate is, or anybody at CMS, I can tell you, because I spent the day yesterday with the former head of Medicaid, nobody knows what any state's match rate is. The entire program is a financial disgrace. And to build on that and add 20 million people without knowing what the second biggest entitlement program in the government is nuts. So I'm all for covering these poor people, but we should go back and how many conferences do you go to and somebody says, let's talk about Medicaid reform? The answer is nobody. And it's the second biggest program in the government, and it's a complete and total disaster, has been for 25 years, and nobody wants to talk about it. Tom Daschle, to his credit, has for years, and he's right. I would take the Daschle reforms tomorrow afternoon. But that's one problem. The second problem is I also think we should subsidize low-income people who need help. I felt that way in Part D, but much like closing the donut hole in Part D is an insane policy. Subsidizing rich seniors for drugs is nuts. 14 million seniors have no co-payments, no deductibles. Covering a rich golfer on the golf course for his drugs in Naples, Florida, to me is crazy. When you're talking about what's going on in the ACA, we're subsidizing people to 400% of poverty. That's 62% of Americans getting significant subsidies for a new entitlement program. That is the fundamental mistake. This issue here to me is not structure. The structure of the ACA, if you go back and look at the George Bush 1, I've said this a lot publicly, I was one of the two people that put together the George Bush 1 health reform plan, and none of you probably remember, in 1992. It looks a hell of a lot like the ACA structurally, with about 40% as much money. It's focused on low-income people. The issue here, as it is with Part D and the drug benefit, is not the structure. I happen to like a lot of the structure of the ACA. I think it's very similar to where Senator Kerry was going 20 years ago, or Senator Dole, or Senator Danforth. It was kind of the mid-ground compromise was individual mandates, exchanges, transfer payments, refundable tax credits. And if you'd asked a Democrat or Republican 20 years ago, what should we do? They would say, we should do the federal employee health benefits plan, which is basically where we're moving with Medicare Advantage, and we're moving with exchanges, and roughly we're moving with Medicaid. So structurally, it's the right thing to do. The issue is, who do you want to subsidize? And when you get into a program where you're subsidizing 62% of Americans, it's insane. And if I went to you tomorrow and said, let's give housing vouchers and food stamps to 62% of Americans, you'd say, I'd have to have my head examined. And the problem you have is this program is going to be incredibly popular. I think it's going to be very unpopular due to the nasty rollout this fall, and I think Democrats will pay for it this fall. But as we've discussed, I think in 2 years it'll be really popular. Why is that? Because people love free stuff. And once you get 62% of Americans getting a big subsidy for health care, it ain't ever coming back, and you're all going to be paying for it. I personally have a big problem subsidizing some people in this audience. I think 62% of Americans for an entitlement program with big subsidies is way, way, way beyond what we should be doing. We should be focused on poor people and low-income people, not the middle class. And $94,400 for a family of four, which is what 40% of poverty is a hell of a lot of people. And once you start, it's not coming back. And that's the problem, and the problem is money.